Okay, great. Good morning or good evening, everybody. I'm Lia Jacobson, an ear, nose, and throat doctor from California. I work with the Mending Kids team, and we are here today with our 4th of 6 audiology lecture series in partnership with the graduate students of the Clinical Audiology program at the University of Melbourne in Australia. We are also partnered with the Bugando Medical Center in Mwanza, Tanzania, and our colleagues there are doing a lot to expand ear surgery and audiology services in Tanzania. And so this lecture series is a sort of international collaboration. So without further ado, I think we still have a few people signing on, but I'm going to turn the screen over to our presenters. Today we have Helene Werda, Stephanie Tai, and Vivian Tran presenting on the topic of vestibular disorders and diagnostic strategies for that.
Hello, and welcome to Vestibular Pathologies. My name is Helene. I'm one of the audiology students from the university, and I'm here with Steph and Vivian to chat to you about this topic. Can everyone see my screen okay? Excellent. All right. So to begin with, I just wanted to briefly chat about the vestibular system and its structure and function. I understand that we have people coming from lots of different places and lots of different backgrounds. So I just wanted to cover kind of the very basics to make sure that we're all kind of on the same page with the things that we'll be chatting about today. So previous presentations, we've chatted about hearing function and the cochlea, but today we want to look at the vestibular system. So the vestibular system has 5 kind of main parts to it. The otolith organs, so the sagittal and the utricle, and then the 3 semicircular canals. And we've just got kind of an image here showing the different structures within those particular parts. So on the bottom left-hand side, I need like a pointer. Anyway, you can see the structure of the semicircular canals where we've got the hair cells within the cupula. And on the right-hand side, we've got the structure of the otolithic organs. And the main kind of difference would be the presence of these otoconia at the top of the macula within the otolithic organs, and that will become more important as we talk about different kind of pathologies and what might be happening for some conditions. As you guys may be aware, the different parts of the vestibular system are responsible for giving us different information about our balance and our position within space. So the semicircular canals focus mainly on telling us about rotational acceleration. So when we're turning in particular directions. And in doing so, head movement in particular or body movement in a particular direction will result in the fluid within the semicircular canals moving in the opposite direction. That displaces the cupula and therefore the hair cells and gives us an idea of the direction that we're moving in and how fast we're moving. And so the semicircular canals are positioned within our 3 dimensions in order to give us that perception of how we're moving, essentially. The otolithic organs, on the other hand, give us an indication of linear or gravitational acceleration. So you've got kind of the utricle and the sagittal that being horizontal and vertical to give us those different types of movements. And they function in a slightly different way. So they've got the otoconia on top. And when we bend forward, for example, gravity causes the movement of that otoconia, and then that's what displaces the hair cells to give us an indication of the fact that we've bent forward and we've changed position. In looking at vestibular function, once the hair cells have moved, they are sending kind of action potentials and neural messages up to the vestibular nerve. And we know that vestibular hair cells are firing all the time. They have this kind of base rate of firing. And the movement of the hair cells changes the way these fire, whether it makes them kind of excited or whether it makes them inhibited. And part of the way the brain interprets information from the vestibular system is to compare the two ears and say, okay, which one's getting excited, which one's getting inhibited, and that comparison tells us about which way the head and the body is moving. One of the important functions of the vestibular system is to play a role in several reflexes that we have in order to maintain our position and our balance. So probably the big one to chat about today would be the vestibular ocular reflex, so the VOR. And this in particular is responsible for helping what we call gaze stability. So it allows us to focus on a point. So it kind of comes into play, for example, if I'm moving my head to each side, but still focusing on the screen in front of me, my eyes are also changing in order to make sure that they're still focused on the screen, even though my head is moving. And that's the VOR working together with the vestibular system and the visual system to enable that to happen. So moving your head in a particular direction results in the movement of the eyes in the opposite direction to make sure that they're still focused on where you want to focus on. Does anyone have any questions at that point in time? Sorry, that was like a roller coaster vestibular in a nutshell. So I hope that wasn't too fast and confusing and all made sense. But yeah, any kind of questions, or should we move on to the pathologies? Radio
so
silence.
at the end of, I think right now everyone can include questions in the chat at the very end. We'll be able to have an open group discussion. So we can open it up to the group for in person. But if anyone in the meantime has questions, please feel free to put it in the chat.
Cool, thanks, Lia. So what Steph and Vivian and I would like to mainly touch base on today is some of the vestibular pathology. So what happens when this system is not working as it should be. So the first of the three pathologies that we'd like to chat through is probably the one that will be most commonly seen, and thankfully is probably one of the easiest in terms of its diagnosis and management, and that is a condition called Bppv, so benign paroxysmal positional vertigo. And essentially it's a condition that is named quite appropriately, really, in terms of the fact that it describes a benign or a non-life-threatening condition of the vestibular system. It's something that occurs in response to movement or changes in position as such. Often episodes are quite brief and quite sudden, and people being a vestibular condition experience vertigo, so that sensation that the world is spinning. So there are kind of couple of kind of different types, but essentially Bppv occurs when the otoconia that we chatted about, which usually sit within the otolithic organs, when they essentially escape and end up in the semicircular canals. And instead of playing a role in telling us about linear movement and in gravity, instead they activate the rotational system of the semicircular canal. So it gives us this perception that we're rotating, that we're spinning when we're not, essentially. So probably the picture on the right-hand side shows it a little bit better. So you can kind of see on the left-hand side, I really need to point it anyway, that you've got the otolithic organs, and essentially those otoconia come loose and they end up kind of in the canal or attached to the cupula, not where they're essentially supposed to be. So we've got kind of two different types, which you can see in the left-hand picture. You've got the cupulothiasis, make sure I got that right, where the otoconia are kind of adhered to the cupula, or you got the canalithiasis, where they're free within the canal. And essentially they play on the mechanisms of each of those different parts of the semicircular canal. So, for example, when you bend over, gravity is acting on the otoconia like you would expect that it should. But rather than displacing the otolithic organs like it usually would, it instead displaces the cupula in the semicircular canal. So the semicircular canal goes, something's happening, I'm detecting movement, you must be spinning. And that then kind of leads to confusion within the system, because the visual system goes, but no, you're not spinning, you're bending over. So this conflict of information coming from the different sensory systems tend to give us the symptoms. So that perception that we're moving when we're actually not. And then that kind of leads on to other symptoms such as the nausea or the emesis that people experience with it. In the canalithiasis, very kind of similar. You've got the movement of particles which give us the sensation that we're spinning when we're actually not. So often a question that gets asked when people come in and you tell them you have this condition is, will I get it again? There's often a sense of relief when you've identified it and hopefully treated it, which we'll go through in a moment. People want to know if it's going to come back. There's a whole list there of risk factors which have been identified as potentially maybe being related to the occurrence of Bppv. But you know, they're not causes as such. So whether someone will get another episode, maybe there'll be a slight increase if they have one of these things, but it's not guaranteed. Probably the biggest predictor of someone having another episode of Bppv is the fact that they've had the first one. So that tells us there's something in the system where the otoconia are a little bit more prone to escaping and heading down to those canals when they're not supposed to. So as I briefly touched on, the main symptom that people kind of report is vertigo as such. Sometimes it's accompanied by nausea and vomiting, but generally episodes are very brief. They happen very suddenly. And the big one that distinguishes this from other vestibular conditions is that it seems to be triggered by changes in position. So people report things like bending down, rolling over in bed, leaning to get something, and all of a sudden they've had the onset of these symptoms. Depending on the type of Bppv that's present, whether it's in the canal or in the cupula, you get a slight variation in how quickly the onset occurs and how long the symptoms occur for. So in terms of what you might see, so you'll have a patient comes in who reports kind of vertigo and nausea, emesis, that kind of thing. But in terms of what you'll actually see, they very much kind of marry up, but we're looking for something slightly different. And we'll go through the assessment in the moment where you might see the presence of these kind of signs. So generally, signs occur unilaterally. So we're looking for Bppv only on one side, although theoretically a bilateral presentation, I guess, is possible. Generally, the assessments involve lying people down and sitting people up in various different kind of configurations. And essentially, we're looking for nystagmus. So nystagmus is something that occurs where we get movement of the eye. And that movement of the eye occurs because the brain thinks that it's compensating for head movement. So as we chatted earlier with the VOR, when the head moves, the eye moves in compensation. So that same process occurs, except the head is not moving, but you still get the eye movement as such, and that's what we're looking for. So we're looking for that nystagmus, and there's a few different types of nystagmus which we'll go through, which give you an indication of which canal is affected. So you might have the eyes moving to the side, you might have them moving up and down, or you might have them actually rotating in space. Generally, it takes a little while, 20 seconds or so for the symptoms to occur once the person has laid down, and that's to give the otoconia time to move, particularly if they're in the canal, and for the symptoms to occur. Generally, the system, after about 50 seconds, gets used to the fact that there's movement occurring, but people will sometimes report that subjective dizziness, not always, but sometimes. Generally, when you sit the person back up, you get nystagmus in the opposite direction. And if you do the assessment multiple times, you'll start to see a fading of the effect. So the sign will fatigue when you do it multiple times. So just probably a little bit, hang on a tick, skip slides. A little bit more on just the type of eye movements that we'll be looking for during the assessment. So we'll be looking for kind of the direction, horizontal, vertical, or whether it's rotational or torsional. We're also looking at what direction the rotation is occurring in. So it might be towards the ground, which we call geotropic, or it would be away from the ground, which we would call ageotropic. So lots of different types of movements that we had to get our heads around as well, in order to kind of identify which canal might be affected, and then what the appropriate treatment would be. So this is just kind of an overview of, when you do the assessment, the type of nystagmus that you would expect to see. Posterior semicircular canal is by far the most common because of its anatomical position relative to the otoconia. So we'd expect an upbeating nystagmus, so the eye is going to be flicking upwards, and we'd expect it to be geotropic, so that the eye is turning towards the ground, so towards the side that the person is laying on. You do sometimes see horizontal and anterior semicircular canal presentations, but they're certainly much, much rarer than the posterior form of it. So I've got a few videos, they're just loading, to look at the different types of nystagmus. Let's see if they'll play. Excellent. Are those playing for you all? Yes, excellent. So you can see in the first one, the eye is flicking up. So this is a form of a vertical nystagmus where you've got the quick eye movements occurring towards the ceiling. They're not the best videos, but getting videos in nystagmus is quite tricky, I found. But if we compare that to the downbeating nystagmus, you've still got that kind of vertical movement, but the quick phase of the eye movement is now occurring down towards the ground. And then we'll compare that to a left-beam nystagmus. So this is a form of horizontal nystagmus. So in this one, rather than the eye flicking up and down, it's flicking more side to side. Cool. No. Now the videos just want to show you all of them at the same time if you want to compare. Next slide. All right. So now that we worked out what we're going to see, now I'll tell you what you're actually going to do. The assessment for Bppv is the Dix whole Pike test. And this is quite a useful test because it's something that you can do in the clinic room without lots of complicated or fancy equipment. So it's something that audiologists do, physios also do it, ENTs, GPs probably to a lesser extent, but if that's what you've got access to, then that's what you've got access to. But essentially the Dix Hall Pike involves laying someone down with their head kind of lower than their shoulders, and the head turned to the side that you want to assess. I've got a video which probably explains it a little bit better. Two different companies have done two different videos. They're both quite nice. So yeah, I'll show you one, but feel free to have a squiz at the other one at some point in time.
The Dix-Hallpike test is used to diagnose this condition. The patient is asked to sit on a bed with legs straight ahead. The head is turned by 45 degrees. The patient is then taken down to the head hanging position 30 degrees below the bed. This can also be achieved by placing a pillow under the shoulders of the patient. Look for nystagmus. In posterior canal Bppv, we see torsional upbeat nystagmus. After the dizziness settles down, bring the patient back to the sitting position. This test is repeated in a similar way on the left side. We need to determine which side causes nystagmus to be able to find out the side of involvement.
Don't play. Go to the next slide for me, please. There we go. Yeah, so that's essentially the not the Epley maneuver, sorry, we'll get to that in a moment. The Dix-Hallpike in a nutshell. So it's a matter of laying the patient down and looking for the presence of nystagmus. So generally, because the condition occurs unilaterally, we'll see nystagmus that occurs on one side, but is typically absent on the other side. So we've got some more videos. How are we going for time? Of different types of Bppv and the canal in which it's occurring. So this first one is the right posterior canal. So there we've got the presence, of nystagmus when the patient's been laid down. And this one's a left horizontal, which is certainly not as common, but will come up occasionally. So not only is it on the opposite side this time, but the form of nystagmus looks different because the otoconia have dropped into the horizontal canal this time rather than the posterior. So the treatment that we use for Bppv also can occur in the clinic room, which is very nice. And it's certainly something that audiologists and physios do. And the good thing is that we can do the treatment each time the patient presents with the symptoms, whether that be months apart, years apart, or decades apart, essentially. So in terms of the main takeaways probably from at least this part of the lecture is being really familiar with the Dix-Hallpike assessment and this first one, the Epley maneuver, in terms of having things in your tool belt for when patients come in with vestibular symptoms, particularly if you haven't got some of the more advanced equipment in your clinic. So as I mentioned, posterior Bppv is the most common, and the main treatment for it is the Epley maneuver. So essentially we're laying the patient down and rotating them in order to get the otoconia back to the otolithic organs where it can be dissolved back into the system, absorbed back into the system. So I'll show you a video. So again, I've got a couple depending on which one you prefer. Trying to think which one was clearer. Let's go with this one.
After determining the side, we start the Epley's maneuver. Similar to the Dix-Hallpike test, the patient is asked to sit on a bed looking forward. Now turn the head by 45 degrees towards the side of Bppv involvement. Make the patient lie down with the head hanging 30 degrees below the edge. Wait for 30 seconds after the dizziness subsides. Now turn the head by 90 degrees to the opposite side. Stay in this position for 30 seconds after the nystagmus settles. Now turn the patient by another 90 degrees to bring the head to the nose pointing down position. Again, wait for 30 seconds. After this, the patient is made to sit up. It has been recommended.
So as you could see in the diagram on the right-hand side, you could see as we turned the patient in the different positions, we got the movement of the otoconia back to the otolithic organs. And probably the main takeaway is to ensure that the patient is left at kind of each step for a sufficient time for those otoconia to move, because if we're not giving them time to move to where we want them to be, we're not going to get the relief essentially of symptoms.
Apley maneuver is
if you have a patient that has Bppv but has difficulties with kind of the neck or back, and you're not confident in doing the Epley with them, and it being comfortable for them, an alternative is the Sermont maneuver. Essentially, it does the same thing, but requires kind of less turning and movement of the neck, so might be preferable for some patients. I'm not going to play the videos, but the links are there for you to have a look at if you come across a patient where you feel that that's going to be appropriate. But for the very vast majority of people, you'll be looking at doing the Epley. On the next couple of slides, I've put in some other maneuvers that you might look at doing if you have a horizontal or an anterior Bppv. They're certainly less common, but you may come across them in the clinic. I won't play them for time, but the links are there if you'd like to have a look. So that's for horizontal.
The Lampert or barbecue maneuver is performed
and the deep hanging maneuver for anterior symptoms. I think, as I mentioned earlier, essentially the maneuvers can be done anytime the patient presents with symptoms. In some advanced clinics, they look at self-training people to do maneuvers to relieve symptoms, but depending on the patient, most likely you'd start with them coming into the clinic and doing it as the clinician, to make sure that it is being done correctly and that they are getting relief of symptoms. And essentially, once they've got the relief of symptoms, we don't need to see them again. They don't need to come back. It's just a matter of them coming back when they're symptomatic, and we can assess it, see if it's still Bppv or if something else has come up, and redo the treatment maneuver. For some people, if after the relief of symptoms they're getting kind of frequent episodes, or they still feel a sense of imbalance in the system, you can look at referring to a vestibular physiotherapist if you have one nearby, and they'll do kind of further exploration, or physios are more than happy to also do the assessments and the maneuvers too, if that is perhaps an easier service for your client to access. Just had a quick case. How are we for time? Would we like to go through the case or skip to the next pathology?
I think, let's see. I think if it's only going to be a couple minutes, we can go through the case, or we could loop back at the end if there's more time, perhaps.
That's right. I'll give you a 30-second case. So we've got Sarah here. She's come into the clinic because she's had recurrent episodes of vertigo that have occurred when she's rolled over in bed. You happen to be at the University Clinic in Melbourne, and you do this amazing bank of assessments, which you may or may not have access to at your clinic, and they're all normal. So, given the fact that she has indicated that she seems to get symptoms with changes in position, we're thinking, I wonder if it's Bppv. So we go and do a left hal pike. And I was going to ask you what you thought it was, but my video tells you. Anyway, we do the Dix hole Pike, and this is what we see when we turn it to the left. So that's kind of giving us an indication that there is left posterior Bppv occurring because of the nystagmus that we are seeing. Pause the video. Yep, done that. Excellent. So in this case, you'd look at performing the Epley or the Simont maneuver in order to treat it, and then asking the patient to come back when they're next symptomatic. Excellent. All right. Does anyone have any questions about Bppv at this point in time? Excellent. On to you, Steph.
Thanks, Helene. Hi, everyone. So my name's Stephanie, and I'll be talking about superior canal dehiscence, which I will refer to as SCD for the rest of the presentation. Next slide, please. So SCD is caused by an abnormal opening between the uppermost semicircular canal and the brain. The condition causes problems with hearing and balance, which I will go through in more detail today. And other names for this condition also include third mobile window syndrome or Miner syndrome. And the prevalence for SCD in the general population is approximately 1 to 2% according to studies looking at cadavers. However, many individuals with SCD may not actually develop associated symptoms or only gradually develop them later on in life. Next slide, please. Oh, sorry, previous slide. So to understand the impact of such an abnormal opening, we need to really understand the other structures around the superior semicircular canal. So the middle cranial fossa, also known as the central skull base, it contains many structures that are very susceptible to pathology. And on each side of the middle cranial fossa consists of the sphenoid bone and the temporal bone. Now, the abnormal opening is typically in the temporal bone in vast majority of the cases. The inner ear is also fluid filled and is almost completely encased in rigid bone. There are areas in the inner ear where there are compliant windows, and these compliant windows connect to the middle ear or the cranial cavity. So two of the most important windows are the oval and round windows, which are responsible for sound transmission from the middle ear to the cochlea. So the oval window is where the stapes is fused to the cochlea, and as the stapes is pushed towards the oval window, a fluid wave is generated, and this results in the round window being pushed outwards. So this fluid motion is then converted into neural stimulation and produces the sensation of sounds and motion in the brain. However, in the case of SCD, a third window is added where an additional compliant area in the inner ear modifies this fluid motion and disrupts the normal transmission. So this results in misdirected fluid and pressure dissipation, which causes the basilar membrane displacement. And this results also in the elevation of air conduction thresholds. And it's also part of the reason why there's a conductive hearing loss that arises from SCD, which I'll talk about in more detail later in this presentation. A supernormal bone conduction threshold, sorry, could you just go back 2 slides? Yeah, a supernormal bone conduction threshold in Tollier's phenomenon is also the result of additional conduction from the bone to the fluid through this abnormal opening. Abnormal vestibular stimulation may also occur due to this abnormal opening. So in the case of SCD, when the oval window is displaced inwards with sound transmission, fluid flows through the ampulla of the superior canal, and this causes excitation and stimulation and results in nystagmus and vertigo. In addition, in patients with SCD, straining or heavy lifting can also elevate intracranial pressures, which also pushes on the opening and causes inhibition of the ampulla, also resulting in nystagmus and vertigo. Next slide, please. So SCD is thought to be caused by birth or developmental defect in the temporal bone. According to current research, in approximately 1 to 2% of the general population, the bones in the head develop to only about 60 to 70% of their normal thickness in the months following birth. Now, this genetic predisposition may explain why sections of the temporal bone may be thinner, making it more fragile and susceptible to damage through physical head trauma or from gradual erosion. And with this, a second event occurs in the vast majority of patients prior to the onset of symptoms. This second event is most commonly head trauma or major pressure altering events such as scuba diving, air travel, or straining. And much less common are erosive processes that can cause the development of SCD as well. And this can be seen with tumors and infectious diseases. Next slide, please. So in terms of the symptoms associated with SCD, it includes unsteadiness and dizziness with straining, loud sounds or pressure changes. Autophony, which is referring to hearing internal noises louder than they would be expected to, such as their own voice or hearing their own eyes moving or blinking. And also hearing loss and fluctuating hearing loss, which I have previously mentioned. Next slide, please. So in terms of signs to look out for in clinic, they include disequilibrium, which may be brief episodes or constant. Imbalance if there is a pressure change in the ear canal. Noise-induced imbalance. So this means they might be complaining about loud noises, such as ambulance sirens or children crying that might make them feel very unsteady. And also low frequency conductive hearing loss. Next slide, please. So in terms of assessment for patients with SCD, audiometric testing often reveals a low frequency conductive hearing loss. And with this, some of the red flags to really pinpoint SCD patients is acoustic reflexes, which are normally absent if there is a presence of air-bone gap. Especially if the clients don't have any middle ear issues as well, that may explain that conductive loss. Bone conduction thresholds are typically at 0 dBHL or better in the low frequencies. And another test which would be more applicable in clinics without equipment or sophisticated equipment is Tulia testing, which can be done to observe nystagmus or dizziness provoked by loud sounds. And this can be done with a TIMP machine or an audiometer, and just by presenting loud tones, for example, at 500 Hertz at loudness level of 100 dB. And after that, just noting the subjective symptoms reported by the patient, rather than using equipment to record eye movement. In addition, dizziness on pressurization from tympanometry may also be experienced by SCD patients. And lastly, a test that can also be used is vestibular evoked myogenic potentials, otherwise known as MEMS, which does require the presence of quite expensive equipment, which might not be available. Next slide, please. So aside from the assessments from the last slide, the most robust method for diagnosing SCD is through a CT scan, which would show the abnormal opening in the temporal bone. Next slide, please. So in terms of treating SCD in patients, treatment can be divided into conservative or surgical. So for many patients, an explanation is all that is really required for them to continue comfortably with their symptoms. Patients with minor symptoms should also be advised to avoid triggers such as loud noises or altitude changes. Additionally, hearing aids may also be beneficial for those with milder symptoms and would like amplification for the hearing loss. For some people who have pressure-induced symptoms, such as driving over a hill or while riding in the elevator, a procedure where an insertion of tympanostomy tube can also alleviate these pressure symptoms by sort of limiting the tympanic membrane extreme movements during pressure changes. And for others, especially those with predominantly pulsatile tinnitus or autophony symptoms, a diuretic may also be factored in to reduce intracranial pressures, enough to alleviate the symptoms to a livable level. And lastly, surgical treatment to close the hole may also significantly improve SCD patients' quality of life. Next slide, please. And now onto the management and referral. This typically depends on how severe SCD is impacting the patient's life, but generally for those who do go down the path of hearing aids, annual reviews for hearing aids would be really important. And most would have been referred onto an ENT. So reviewing their audiometric thresholds upon request by the ENT is also important. Next slide, please. And to finish off, just a very quick case. So John here is a 35-year-old male, and he presented with intense episodic vertigo triggered by loud sounds. Blowing his nostrils also induced slight vertigo, as well as vertigo during testing. And as you can see, he also has a low frequency hearing loss. John was then referred to an ENT, and appropriate management that he was comfortable with, such as surgery, was done. And that concludes the SCD portion of today's presentation. So I'll now pass it on to Vivian, who will talk about Meniere's disease.
Hi everyone, so I'll be talking about Meniere's disease. Next slide please. So Meniere's disease is when there is an accumulation of endolymph in the cochlear duct as well as the vestibular organs. So on the right diagram, you can see that the organs have been dilated. Next slide. So the clinical presentation of Meniere's can vary between individuals. It's often occurring in individuals between the age of 40 and 60. It's more common in women, and although Meniere's may start off as unilateral for most cases, about 50% of the cases do become bilateral. Although there is no known exact cause for Meniere's yet, however, there are potential causes such as stress, alcohol use, family history of the disease, smoking, and fatigue. Next, please. So some of the common symptoms of Meniere's include recurring spontaneous episodes of severe vertigo. And when there is movement during the episode, it actually exacerbates the vertigo. Often it's unilateral initially. There is also a fluctuating sensorineural hearing loss where it starts in the low frequencies initially. Some patients would also experience tinnitus as well as oral fullness. Next slide. In general, there are 3 stages of Meniere's. However, everyone experiences Meniere's differently, and the stages do vary from person to person, and not all people will go through these 3 stages. However, I'm just going to go through a general overview of the stages. So for stage 1, Patients would experience severe vertigo that causes nausea and vomiting, and this episode can last from 20 minutes to several hours. They can also experience oral fullness in the ear, and there is also a low frequency sensory hearing loss that they would experience during the episode. So if we look at the first diagram, their hearing is normal when they're not experiencing the episode. However, when they are going through the episode, their hearing does fluctuate and go down. Tinnitus will also be a symptom that some clients will experience, and that can last for several days. Next, please. So for stage 2, the clients are still experiencing severe vertigo, and by now there is a hearing loss that has been established. So in the top diagram, we can see that the baseline hearing has actually worsened. However, each further episode of Meniere's that the client does go through, the low frequency sensory hearing loss also worsens. So in the second diagram, we can see that during the episode, it also goes down and that the low frequencies sensory hearing loss worsens. By now, tinnitus is likely to be permanent, and the patterns of relapse and remission actually varies. So sometimes the attacks can come in clusters, and then there could be long periods of remission. Next, please. And by stage 3, by now, the hearing loss is severe and permanent. It no longer fluctuates like stage 1 and 2. And this becomes the actual main symptom of stage 3. Recruitment is also common. So that's when loud sounds become, clients become hypersensitive to loud sounds. And they can also experience diploceusis, which is when sound pitches are altered. And this is likely due to the excessive amount of endolymph in the ear that changes the manner of how sound waves are entering into the inner ear. But by stage 3, often vertigo diminishes and there's less frequent attacks. Next, please. So in terms of how to diagnose Meniere's, there are several factors and results that we should consider. So it's really important that we take a thorough patient history and note down the symptoms that they are experiencing, as Meniere's disease symptoms are very distinctive. For example, the recurring severe vertigo that lasts several hours, the fluctuating hearing, and the unilateral symptoms such as tinnitus and oral fullness. So if a patient comes and they present those symptoms, it's a red flag that it could be Meniere's. And if it's possible, we would also want to do an MRI to exclude acoustic neuroma, which has similar symptoms, but not exactly the same. We would also want to do some monitoring of their hearing levels, especially the low frequencies, because that's a common feature that we would see, the fluctuating of the hearing. And then there is also a test that we can do, which is called the bedside hit. And this can help identify unilateral horizontal semicircular canals dysfunction, which occurs in the later stages of Meniere's. Next, please. So for the bedside hit, the procedure would be the clinician would face the patient and they would hold the patient's head firmly. The patient is instructed to maintain their gaze on a target, and most of the time it's likely to be the clinician's nose. And the clinician would give the following instructions, such as, I'm going to move your head in quick and unpredictable movements. I want you to keep your eyes on my nose at all times. Following that, the clinician turns the patient's head in the horizontal plane in quick and unpredictable movements, around 5 to 10 times impulses on each side. For a normal result, what you would see is when you turn the head very quickly from either direction, the patient is able to maintain their visual focus on the target, even though their head moves, so their eyes would still be on the nose. However, when you get an abnormal result, when you move the heads, the eye movements moves with the head along when it's moved instead of staying on the target, and then the eyes will need to do a corrective or catch-up saccade to move back to the target. Helene, if it's possible, can you play the video?
perform the test, the examiner sits in front of the patient and places a hand on each side of the patient's head. The patient is instructed to focus on the examiner's nose, and the examiner focuses on the patient's eyes. The patient should keep the eyes open even if vertigo symptoms worsen. Now the examiner quickly turns the patient's head towards the side to be tested while watching the patient's eyes. The test is positive for peripheral vestibular dysfunction if the patient's eyes move away with the head and then quickly return the gaze to the clinician's nose at the end of rotation. This is called corrective saccade, which occurs due to an abnormal vestibulo-ocular reflex.
Yeah, thank you. Next slide.
Perform the test, the examiner.
Oh, good. There is also the AAO-HNS criteria that we can also use to help identify Meniere's. So some of the criteria are 2 or more definite spontaneous episodes of vertigo of 30 minutes or longer, documented hearing loss on at least one occasion, and then there is a criteria that we look at regarding the hearing loss, tinnitus or oral fullness in the symptomatic ear, and then other causes excluded such as vestibular migraine and acoustic neuroma. Next slide, please. Although there is no cure for Meniere's, there are some methods that we can do to help manage the symptoms. For example, like I said, stress was a potential cause. So maybe lifestyle changes is something we can consider. For example, counseling to help manage stress. Dietary is also something that can be a cause. For example, salt, the intake of salt, cacao, caffeine, and alcohol can actually induce Meniere's. So we might want to consider reducing salt and cacao, caffeine, and alcohol in our diet. There are also some drug therapies that we can also consider. For example, diuretics to help reduce the fluid in our body, especially the ears due to the endolymph. Some beta-histine, which also dilates the blood vessels in the cochlea to get more vascularization through. There are also some medications to assist with the vertigo symptoms. And for the clients that have the hearing loss that's been established, it's also recommended to get a hearing aid to help clients with their hearing. Next, please. There are also some non-destructive surgeries that can be performed on the client. So the tube insertions are placed and thought to influence the inner ear pressure by stabilizing the middle ear pressure. And they mainly help in reducing the sensation of fullness and possibly reducing vertigo. And it's good with the tube insertion because there's no risk to the client's hearing. The Endolymphatic Sac Surgery is a surgery where they open up the sac to try and drain the endolymph. And that's also good because there's less chance of a permanent hearing loss from the surgery. Next, please. However, for clients that are experiencing extreme vestibular symptoms and it's just something that they can't cope with daily, we may want to consider knocking out the vestibular function to relieve the clients of the symptoms. So chemical intratympanic gentamicin can be injected through the tympanic membrane into the middle ear, which is then absorbed through the round and oval windows. And that damages the inner ear and the balance organ when it is applied, and that decreases the episodes of vertigo. We can also do labyrinthectomy, which is a surgery that requires us to drill through and remove the labyrinth, which is made of the vestibular organ, semicircular canals, and cochlea. And by removing that, diminishes the cause and the driver of the sudden vertigo attacks. However, that's ideal for clients with very little hearing because that does impact their hearing. And so with these two methods, it's important that we really talk to the clients regarding the possible outcomes of the surgeries, as most of the time these two methods can actually impact the client's hearing. Next, please. So I'm just going to go through a case study. So we have Andy here, and over the last 8 months, he's experienced 3 episodes of vertigo, which lasts around 40 minutes each, and he's experiencing nausea with them. And around 1 hour before the episodes, he would often sometimes notice that his right ear would feel blocked and that his hearing is muffled. And then it returns back to normal again. And he feels unwell for half a day after the episodes, and then he would also return back to normal. And he has done an MRI, which means that, and it's come out that he's clear of an acoustic neuroma. Next, please. So what we did was we did an audio, did some hearing assessments on him, and his left ear was normal. However, in the right, we can see that there's a mild sensorineural hearing loss in the low frequencies. He has type A timps for both ears, which means that he has normal middle ear compliance and speech is consistent. Next, please. We also did a bedside hit on him where the left, when his head was turning to the left, he was still able to maintain his gaze on the target, which means he has normal horizontal semicircular function on the left. However, when we were doing the right, he was unable to maintain his gaze on the target, and we were noticing that there was a corrective saccade every time we were turning his head, and that's indicating that there is abnormal horizontal semicircular canal function on the right. Next, please. And so from that, and when we go against the criteria to see, we've noticed that he's had more than 2 vertigo episodes, and he has a change in his hearing, that fluctuation, and he's also experienced the symptoms in his right ear, the tinnitus and the oral fullness. We can also likely consider the last point too, because we did do an MRI and that excluded the acoustic neuroma. And so from that case, we can likely diagnose Mandy. We can diagnose Andy with Meniere's due to him fitting all the criteria. And that's it for my part. So we're gonna do a quick quiz now. And it'd be nice if we could get some participations, just so then it's not just us talking all the time. Helene, do you want to take over with the quiz? Or
Yeah, I'm also going to just say I want to be respectful of everyone's time. We're at the hour. We can go ahead and do the quiz, but if anybody has any questions, if you could type them into the chat, we will try to get those answered, and then maybe go about 10 more minutes here for anyone able to stick around.
Cool. All right, we got 5 easy questions on our 3 pathologies, so feel free to pop the answers in the chat, and we'll see what you're all thinking. So first one is all the way back at the beginning, looking at Bppv. So if you have a horizontal form of the condition, what type of nystagmus would you expect to see on assessment? Yeah, I didn't give you any multi-choice, sorry. I was a bit mean when I wrote the questions. No takers. I can see some audiology students from the university. I'm expecting input, guys. That's right. I know you're just all individually doing it at home, I'm sure. Next question. Steffi gave you a multiple choice one. Which of the following symptoms is not associated with SCD? What will you not expect to see? Autophony, noise-induced vertigo, sensorineural hearing loss, or low-frequency conductive hearing loss?
So for the participants, if you just want to put a letter into the chat, that way we can gather some responses.
Maybe not. That's
Maybe
okay.
not. Yeah, it's
okay.
also a lot of people are on their phones, so it might be challenging for people to respond
It
on.
is. Yeah. All right, let's have a go at question 3. Which of the following is an indication of stage 3? A, B, C, or D? So fluctuating hearing loss or permanent hearing loss, lots of vertigo, less vertigo. Which one do you think? Oh, I see a chat. Give us the answers. Don't you know the answers, Chris? At the end. We're going to do all 5 questions and then we'll put the answers up at the end. Is that okay?
It may just be easier to do them during, well, whatever you guys want to do. We're almost done. So.
Oh, okay. What is the treatment for posterior Bppv? Someone walks into the clinic and you've identified the nystagmus and diagnosed posterior. What are you going to do now? And last question, what assessment are you going to do to investigate a sound or noise-induced nystagmus and vertigo if you think there is SCD? All right, answer time. There you go. So if you've got horizontal Bppv, you'd expect horizontal nystagmus. If you think there is SCD happening, you would not expect a sensory neurohearing loss, you'd expect a conductive one. If you're at the stage 3 of many airs, you're starting to look at having a permanent hearing loss, but thankfully the vertigo would have subsided. Back on Bppv, if you think you've got a posterior case, you try an Epley or Semont maneuver and see if that relieves symptoms. And if you're investigating symptoms for SCD and you're noticing that they seem to be getting sound-induced nystagmus and vertigo, you would try the Tullio test and see what the results are. So we are at the end of vestibular pathologies. Does anyone have any questions? Or I should ask, what questions do you have?
Yeah, and we can open this up to the audience, Choe and Miles, if we haven't already. It's a really robust topic, and I know not necessarily the most simple topic in ENT. So this one might take people some time to digest the lectures. If you guys are willing to share the lectures, we've had some requests for that on the back end on what's happening.
Definitely. So. Sorry, that's my watch. I don't know if that came through the mic. Cool.
Okay, well, thank you guys so much for presenting, and to our audience. I think if you guys are okay with it, if questions do roll in after some time, we can forward them on if that would be okay. And but yeah, thank you everybody for joining us this evening. And I believe our next talk is in a week. So we took a break for a couple weeks, and we'll have our 5 out of 6 next week. So thank you very much.